Okay. Good evening to you all. Welcome you all for a new session of theory in ERPM. So I may be familiar to some of you guys, Charita, Samir, and all, but I may not be familiar to the most of the junior students. Okay. So let me introduce about myself briefly. I'm Dr. Vasanta De Silva. I'm one of the obstetrician and gynecologist consultant, and currently I'm working in District General Hospital, Mena in Sri Lanka. So I have been in this field of ERPM as a teacher over last several years, long time. However, last year I was not in the field because I was not in the country. Now I'm back, so I'm happy to conduct this teaching again. Okay, right. So Darwane, I know that there are some Sri Lankan students who have joined to this session, and there are some foreign students also join with the session. So this today I'm going to discuss about what is called antenatal care in Sri Lanka. Okay, so when it comes to antenatal care, Darwane, it may be slightly different from other countries. Say, for example, if you are an Indian, right? So the antenatal care in your country may be slightly different from what we have in Sri Lanka. So on the other hand, if you are in countries like the developed countries like North America or somewhere, right? So the antenatal care is again going to be different. Okay. So what I'm going to discuss today is antenatal care of Sri Lanka, but those who interested with these theory sessions later, so we'll be discussing all other obs and gynae topics in detail, right? So when it comes to the management, there is no difference whether you are an Indian or whether you are a Sri Lankan or whether you are living in a developed country. So the management is almost same, but antenatal care, there can be slight changes in between countries. Okay. Right. Okay. So let me give you a brief introduction about this subject, ONG, obstetrics and gynecology. Daruni, can you all please switch on your cameras and focus on your lovely faces? Right. I know that some of you guys are in the boarding places, so don't worry about those things, right? Just focus on your faces because it's going to be live then. Okay. Right. So when it comes to this obs and gynae, Daru, now, when it comes to your ERPM exam, you have 6 subjects, I suppose. That is medicine, surgery, pediatrics, and obs and gynae are the 4 main subjects. And you all have the psychiatry and community medicine also. Community medicine, psychiatry, and forensic medicine also. So altogether 7 subjects. So it's not an easy job. Okay. But if you all are planning for the exam, if you have a proper plan right from the beginning, that target can be achieved. So I'm going to discuss about obs and gynae, not about other subjects. So when it comes to obs and gynae, the quantity wise is small. If you compare with medicine, you have lots of things that you need to remember. But when it comes to obs and gynae, right, most of the stuff in obs and gynae, right, can be covered with a small pen, right? This is the area of interest. Okay, so some people think that okay, obs and gynae is a small subject, you can come up very easily. No, when it comes to this is the quantity, but when it comes to the quality, the subject is totally different from 3 other main subjects. Okay, so you need to pay equal attention on this subject as well. Because when it comes to your next target is your theory exam. When it comes to the theory exam, obs and gynae is one of the subjects which is going to determine your future. In the sense, time to time, this paper, obs and gynae paper, it's going to be the critical paper for your exam. That means most of the guys going to repeat with this obs and gynae paper. Okay, so my advice is that you have to pay equal attention on all four main subjects. Otherwise, it's very difficult. It doesn't mean that you have to ignore the other minor subject, but pay more attention on four main subjects. Okay, pay equal attention on absentee also. And when it comes to the exam, your theory exam, you all know that you will have 25 MCQs and 25 SBAs. MCQs and SBAs. So when it comes to the SBAs, like SBA means they will give a 10, they will give a scenario. Say for example, they will give a scenario regarding antenatal care in Sri Lanka. You need to find the best or the most suitable answer out of 5 options. Out of 5 options, you need to select the most correct or most relevant the answer out of 5. So if you see the 5 options given, they all looks like twin sisters, right? Like in this picture, right? They all look similar, but there can be slight differences. Some are skirt is a body, some are skirt is something like that. There can be slightest differences that you need to identify when it comes to the exam. Okay, so we will discuss about this the questions and all when it comes to the revision courses, right? So today, as I mentioned, we are going to start the antenatal care in Sri Lanka. Okay, antenatal care in Sri Lanka. So, sorry. So what is the meaning of this antenatal care? Right? Antenatal care. You know the care. Care is the care, that the normal care that you are going to offer. What is anti? Uncle's wife? No. What is anti? Before. Natal means what? The delivery process. Before delivery, care is called antenatal care. So when you talk about the subject of antenatal care, that includes the care that you are going to give or you are going to offer to this lady before the delivery. Before delivery, from the time of conception, what is the care that you are going to offer to this lady? Actually, when it comes, suppose this is the time of conception. Suppose there were no parents at home today, so the ovum was released and the sperm also came and the life begins. This is the conception. The sperm made with the ovum is called the conception. Suppose today, today the conception happened. Okay, right? Conception happened. So this is the time where the life begins, the pregnancy begins. Suppose this is the time of delivery. This is the time of delivery. So antenatal care means the care you offer to this lady from the time of conception up to the delivery. However, when it comes to the concept of antenatal care, that doesn't include only this period. The proper antenatal care starts with what is called preconceptional care. Preconceptional care. This is the conception. Preconceptional care means even before the pregnancy begins, you have to offer them some kind of caring, some kind of counseling, some kind of treatment for them. This is called pre-pregnancy care. Okay, so today I'm going to start with the pre-pregnancy care. That means if a couple, say newly married lovely couple, right, they are planning a pregnancy. So before they conceive, before they begin with the pregnancy, they have to undergo what is called this pre-pregnancy care. So I'm going to discuss that part also. Then after that, once they conceive the pregnancy period, you can divide as trimesters. First trimester, second trimester, third trimester. It's not exactly 3 months. trimester, though you say that trimester, it comes as, you know, first trimester means Darwani. First trimester means up to 12 weeks. Up to 12 weeks you consider as first trimester. Okay, Turi, right? That is called first trimester. Yes, good. Then what is second trimester, Darwani? After 12 weeks, Kinkini, up to 28 weeks. So if I draw it this way, right? After 12 weeks, Darwani, up to 28 weeks when Sri Lankan set up, it is considered to be the second trimester. This is the second trimester. So this duration, this time gap, vary according to the country where you live. Some of the countries, in some of the other countries, right, they consider this second trimester only up to 20 weeks, up to 24 weeks. But in Sri Lanka, in Sri Lankan setup, you go up to 28 weeks, the second trimester. The reason is, Darwani, if you deliver a baby in Sri Lankan setup at 26 weeks, 27 weeks, the chance of survival is very low. Most likely those babies going to die. Even though these pediatric people are doing 1,000 tons and tons, they can't make them survive at 26 weeks, 27 weeks. Right? So if you deliver after 28 weeks, there is some hope. So because of that, in Sri Lankan setup, the second trimester goes up to 28 weeks. The third trimester begins afterwards up to the time of delivery. That is the third trimester. Okay, Darwani. So this is the first trimester, second trimester, and the third trimester. So you should know, for your exam point of view, as well as for your career, future career, what is the care that you are going to offer before pregnancy? That is called pre-pregnancy. First trimester, second trimester, third trimester. Like that, you should know what is the care that you are going to offer. Okay, Darwani, right? Right, good. So we will first discuss what is this pre-pregnancy care. So first I'm going to discuss about this pre-pregnancy care. Pre-pregnancy care. Now you all know pre-pregnancy care means before the conception, before the pregnancy begins. Hey Shamali, what is the care that you are going to offer? So in ideal situation, if you talk about the ideal situation, any couple who is planning a pregnancy, maybe even ERPM students, right? If you are planning a pregnancy, right? One of the thing that you need to do is you have to go and meet a medical professional and get some advices regarding the pregnancy. Pregnancy can be how is pregnancy? What are the things that you have to do? Am I suitable to become a pregnant woman? Something like that. You have to get some counseling, some assessment. This is called the pre-pregnancy counseling. So, say for example, suppose there's a newly married lovely couple, right? Before the lockdown, they married anyhow, right? Now they are planning for a pregnancy. Okay? Now they ideally have to go and meet a medical professional. Okay, not a Sastra Karya or a Kendra Karya. You have to go and meet with a medical professional and get some advices pre-pregnancy. Now suppose you are the medical professional in this clinic. Okay, so you are in the hospital in this clinic, pre-pregnancy clinic. This couple comes. What are the things that you are going to do? First of all, put a smile, right? Something like that. You just have a chat with the couple, and they will say, "Doctor, we are planning for a pregnancy. Doctor, please give us some advices because we are new to the field." Okay, right. So, as a doctor, what are the things that you are going to do there? So as doctors, you all are trained to analyze a patient. So your analysis start with always history, right? So you take a history from the patient. You first talk with the female partner, then you can talk with the male partner also. Get a detailed history. Okay. Like something like not like that, right? You get a medical history, any of the past medical problems, whether you had any major surgeries before, right? Any cardiac problem, any asthma, any epilepsy, or any neurological problems, any renal problems, something like that. You know the history, you take a detailed history to see whether any problems with this couple. You'll get the history from the male as well as from the female partner. And then you do the examination. From top to bottom, you do a general examination. Lipstick, something like that. You do a general examination from top to bottom. Like, you know, what are things from top to bottom? You can see whether she's pale or not, right? Any neurological signs on the eyes and the oral hygiene. Right, something like that, to oral hygiene, and come to the thyroid, have a look, any goiters, all right? Then come down, right, breast, of course, in this examination, you don't have to go into detail, but it depends, right? So have a quick look. You don't have to expose the patient and all, right? They are newly married, so she may be shy and all, right? Husband may be staring at you, something like that, right? So you don't need to expose, but you know, just ask any problem with your breast, something like that, and come down and see on the patient's hand any clubbing or any problems, right? Especially auscultate the heart and see any murmurs or any cardiac symptoms, okay? And come down and see any problem. So top to bottom, you do a general examination, including the cardiovascular system. That is very important. Okay. So those things should be done when the patient comes to you. And if you have detected any special problems, say for example, patient was not a non-patient with a heart problem, but when you examine, there was a murmur. Pansystolic murmur radiating the axilla. What is that murmur? What is the condition? Right? So, like, you know, mitral regurgitation or something like that, or you do the examination. If there is any problem that you have detected, you have to do relevant investigations as well. So, history, examination, and investigations. These investigations are optional. If you have detected any problem only, you have to do some investigation. If you have detected here at the patient is anemic, do full blood count to see the hemoglobin level, something like that. But history and examination you must take. Okay, Darwin, right? So you have taken a history, you have done a proper examination, and couple looks low risk or uncomplicated. Okay, just 1 second, Darwin. Okay, sorry. So now most of the cases, these couples are otherwise healthy, uncomplicated. So if they are uncomplicated, no complications are okay. If they are uncomplicated, what are the advices that you will give? So you can put a label on the patient's chest, fit to become pregnant. Something like that. No labels, right? But you have to tell the couple, look, you are low risk. You can't say no risk, but low risk. Okay, you are low risk couple for a pregnancy. So it's okay to become pregnant. However, all ladies who are low risk or uncomplicated, you have to offer them preconceptional folic acid. Folic acid. Okay, what is the dose of folic acid, Darwani? What's the dose of folic acid? The ideal dose of folic acid is, Darwani, 0.4 milligrams. 0.4 milligrams. Or 400 micrograms, whatever the way. Okay. But the problem is 0.4 milligram tablets are not available in Sri Lankan setup. So normally you give 1 milligram tablets, folic acid. Because folic acid is a water-soluble vitamin, so even you take in higher doses, that doesn't retain in the body. So no problem. Okay. So give them 1 milligram folic acid. Okay. However, in your history, if you have detected that this patient is an epileptic patient, oh, this patient in her last pregnancy had a baby with anomalies like neural tube defects like meningocele, spina bifida, and encephaly, all these problems. In that case, you have to give, yes, 5 milligram folic acid thyroid. 5 milligrams, not 1 milligram. Who else can it? Those who are obese. If the woman comes like this, doctor, I want to become pregnant, give her 5 milligram folic acid. Just 1 milligram is nothing for her. Okay, so those who are having epilepsy, those who had the neural tube defects babies before, chronic diabetic patients, obese patients, give 5 milligram folic acid. Those are MCQs that are. Okay, give 5 milligram folic acid. Okay, and you have given folic acid, whatever the dose, and you have to make sure that patient is immune for rubella. Immune for rubella. Okay, so when you take the history also, you can ask from the patient, were you immunized against rubella? Right? So in Sri Lankan setup, in our immunization schedule, all school girls are given this rubella vaccination. So school otherwise you can ask from the lady whether you were given rubella vaccination. Okay. If she's not sure about rubella vaccination, so what you can do? You don't know whether she was immunized against rubella or not. What you can do? You can check rubella antibodies. Rubella IgG antibodies. IgG antibodies. If IgG is positive, that's okay. If IgG is negative, what you can do? Sasantika. If IgG is negative, what you can do? She is not immune for rubella. So you can give the rubella vaccine now, right now. And if you are given a vaccine, ideally, you have to wait at least 1 month to become pregnant. If you can wait for 3 months, that is much better. You know, the husband they ask them to wait at least 1 month prior to conception. Okay. So if you tell the patient, okay, now we have given rubella vaccination, don't have sex for 1 month, is that practical? No. Lockdown, you know, people are at home, working from home, right? A lot of problems are there. Rainy days, so a lot of problems are there. So during that period, best thing is give them some short-term contraceptives like OCP, 1 month. 1 month, something like that. So you give a OCP or some kind of short-term contraception for them. Okay, right. So make sure. So pre-pregnancy care, you have to make sure the patient is taking folic acid. Recommendation is you have to take at least 3 months prior to conception folic acid. Okay, folic acid, and you have to make sure that patient is immune for rubella. If not immune, give the rubella vaccination. Postpone pregnancy at least 1 month. Is that clear, Darwani? That is the management that you do if the couple is uncomplicated, no other medical problems. Okay. On the other hand, there may be a patient who is a non-rheumatic valvular heart disease patient. Okay, rheumatic valvular heart disease patient, or who may be a non-epileptic patient or a diabetic patient. Whatever the medical problems comes for the pre-pregnancy counseling. Then what do you have to do there? You have to get the history, you have to do the examination, and you have to do relevant investigations also. And if you come across a patient who is having some long-standing chronic medical problems, you can't manage that patient alone. Okay? If you are an obstetrician, you can't manage a medical patient. Or you can't manage a surgical patient, something like that, right? So you are specialized only in one field. If I'm an obstetrician, I can't do other subjects like comment or any other subject I can't do because I'm not specialized in that field. I can do only obs and gynae. Okay, so only one consultant is specialized in only one field. He can do only that field. Okay, something like that. So the only if you come across this kind of a complicated patient, you have to always refer this patient to relevant specialty and get their opinion. Relevant discipline and get their opinion. If the patient is a cardiac patient, you have to refer to a cardiologist. If the patient is an epileptic patient, you have to refer to a cardiologist. So you have to refer to a neurologist. If the patient is a diabetic patient, you have to refer to an endocrinologist, something like that. So you involve the other people also for the management of this particular patient. This is called multidisciplinary care. Multidisciplinary care. Multidisciplinary care. So this is extremely important term, especially when it comes to your vivas. In your viva, right? So after completion of your theory, you will have to face for your viva exam. So in the viva exam, at least mention about this term at least once in your viva. Because just multidisciplinary care and vanish. That count a lot of marks. This word, multidisciplinary care. Multidisciplinary care means that you join the other specialties, other people also for the proper management of this particular patient. Okay, right. So, say for example, you detected a murmur, you have referred to a cardiologist and get the opinion from the cardiologist whether she is suitable candidate for a pregnancy or not. If the cardiologist says, okay, Machan, she can undergo a pregnancy with minimal risk, then you can tell the patient, okay, look, you have a smaller risk, but it's okay to have become pregnant. On the other hand, if the cardiologist says something like that, right? This woman is having extremely high risk for a pregnancy. It's absolutely contraindicated for her to become pregnant. Something like severe pulmonary hypertension. In that case, you have to counsel the couple and you have to give them a proper contraceptive advice. So something like that, you have to manage accordingly. So this is called multidisciplinary care. And they also should be given rubella vaccination. They also should be given folic acid supplementation before the pregnancy if the woman is suitable for pregnancy. Okay, so this is altogether is called pre-pregnancy care. So what are the components in pre-pregnancy care, Daruni? You have to get the history, do an examination from top to bottom, and do relevant investigations if necessary. Okay, if they are low risk or minimal risk, give them folic acid and make sure that they are immune for rubella. Those are the two things. If they are complicated, you have to arrange multidisciplinary care. Multidisciplinary care. Okay, and also if you are planning for a pregnancy, then you have to make sure that she is taking folic acid and she's immune for rubella as well. Okay, so shall we all take a deep breath? Right? So take a deep breath and refresh your lungs. Think something interesting, like Galvanis or Malupang or something. Something interesting, not about obs and gynae. It's not that interesting. Okay, right? So are you all clear about what is this called pre-pregnancy care? Is that clear? Right. Now then come to the pregnancy proper. Now this couple, there's a couple, they conceive and they are coming during the first trimester. First trimester means from 0 to 12 weeks. In Sri Lankan setup, most of the cases, they don't come for the pre-pregnancy counseling. They just come, they do everything other than pre-pregnancy counseling. So pregnant with the they will come to the clinic. So normally in Sri Lankan setup nowadays, right, they are usually coming in the first trimester. That's a very good thing. Okay. So the first time when they come to the clinic, that is called booking visit. What is booking visit, Daru? Do they come with a book like this, come to the clinic? No. What is booking visit? Booking visit means the first visit. They will come and meet a medical professional. Booking visit. So suppose this lady comes at, say, for example, at 10 weeks, she is coming. The couple is coming to an antenatal clinic now. Okay. So from this time onwards, conception is called antenatal clinic. That one was called pre-pregnancy counseling clinic. Okay. Right. So suppose for the first time she's coming, now she's pregnant 10 weeks. What are the things that you will do? What are the things that you will do? Now she's pregnant. Same thing, Darwin. Now, as doctors, we can do only 3 things: history, examination, investigation. Okay. So you start from the beginning, ignoring that she didn't come to the pre-pregnancy counseling, whatever it is, right? You start your counseling or your assessment from the beginning: history, examination, investigation. So you take all the histories, right? Security like that. So you get the proper history. Okay. And you do the examination as usual from top to bottom. You have to do the general examination, including the cardiac assessment. And Darwin, when they are pregnant, definitely you need to do some investigations during the first visit itself. What are these investigations? You have to do that one. Blood group. Blood group. It's very important to know the blood group from the beginning. So we are interested whether you are a positive blood group person or an RH negative person. Because RH negative patients are complicated. That's a separate topic we will discuss later in detail. Okay. So blood group you need to know. Then the full blood count. Why you want to do a full blood count? You can assess the hemoglobin level of the patient as well as the platelet count. Okay, so do a full blood count. What are the investigations already in Sri Lankan setup that you have to do? In Sri Lankan setup, because as Asians compared to Sudha people, right? The Caucasians. Compared to Caucasians as Asian, whether you are Sri Lankan or an Indian or a Pakistani, whoever it is, as Asians, we are genetically predisposed to diabetes. So in Sri Lankan antenatal care, there's a recommendation: all pregnant mothers should undergo screening for diabetes at booking visit. Screening for diabetes at booking visit. Okay, so you have to screen all mothers. All in the sense, those who are not non-diabetics. So all not non-diabetics, you have to screen them at booking visit for diabetes. So those days, people use a test called OGCT, oral glucose challenge test. It is easy to do. How you do OGCT is, whenever the patient comes to you, you ask the patient to swallow 75 grams of glucose in 300 ml of water. These are in 300 ml, 75 grams of glucose. Ask them to swallow. Within 15 minutes, patient has to take all 300 ml within 15 minutes, and you check the blood sugar afterwards. After 2 hours, you check the blood sugar. So that is called OGCT. Okay. So you can do that test also, but because of some problems with this sensitivity problems with this OGCT test, nowadays we mainly go for another test that is called OGTT, oral glucose tolerance test. Tolerance test. This is the gold standard diagnostic test for diabetes, OGTT. How will you do that? How will you do that? You ask the patient to, for this test, Darwin, you have to prepare the patient. How will you prepare the patient? You ask the patient to keep fasting for at least 8 to 10 hours, 10 hours fasting. And you check fasting blood sugar. Fasting blood sugar. Then you give the same dose of glucose, 75 grams of glucose in 300 ml of water. You ask the patient to swallow within 15 minutes, and then you check blood sugar after 1 hour after taking the glucose. And you check the blood sugar again 2 hours after taking the blood sugar, the glucose. So you have to get 3 values: fasting, 1 hour, 2 hours. So if any of these values are above the cutoff, then you consider them as diabetes. Okay. In all these you will get only 1 value. No fasting value, right? Only 1 value. Whereas OGTT, you get 3 values. So which one is more reliable then? Which one is more reliable, Hekaraji? That is OGTT. Okay, so OGTT is more reliable. However, OGCT is more practical. Why? Whenever the patient comes to your clinic, patient doesn't need to be on fasting. You can straight away do the OGCT test. But the OGTT, it takes time. You have to prepare the patient. Patient have to come on another day to get done the test if she is not fasting. Okay, right? So there are pros and cons, but nowadays mostly people are going with OGTT. So whatever it is, blood group, full blood count, OGTT, and what else? What are the other blood tests? You have to do in Sri Lankan setup what is called VDRL, Venereal Disease Research Laboratory Test. You don't have to remember that long name. VDRL. Why this VDRL, Daru? What is the purpose of VDRL? VDRL is to screen for syphilis. Syphilis. Now in Sri Lankan setup, syphilis is almost eradicated. Almost eradicated, but still, it's a must to do VDRL test. Okay, Zamira? Right? You have to do VDRL test. And if facility is available, some of the centers, they don't have a facility, but in some centers, they have facilities. So if facility is available, you have to do HIV screening test also. HIV ELISA. HIV ELISA test. Then it's an optional thing. And also, with regard to urine, you have to do urine full report. So these investigations should be done in each and every patient when they come for the booking visit. What are the investigations that are made? Blood group, full blood count, OGTT or OGCT, VDRL, HIV, plus or minus HIV, and urine full report. Okay, right? So you have to do all these tests right at the beginning. Then at booking visit, you have to arrange another very important test that is called a scan, actually. That is called a dating scan. So you have to, in addition to them, you have to arrange what is called a dating scan. Dating scan. Dating scan. This is one of the mandatory scans during pregnancy, a dating scan. Okay, so as name implies, Daru, dating scan. This scan is mainly to correct the pregnancy dates. Okay, correct pregnancy dates. So best time to do this scan is between 10 to 14 or 11 to 14 weeks. 11 to 14 weeks is the best time to do a dating scan. Remember, 11 to 14 weeks. Okay, and When you do this scan though, there are various information that you can get. Darwani, if you all can switch on your cameras, I can see your faces, then I can see whether you are boring, whether you all need a break, or something like that. I can gain an feedback from your faces. That's why I'm asking you all to keep your cameras on. If possible, please keep your cameras on. Okay, just for me to get it, because doing these online classes is not enough. It's so boring. It's not like a live class, right? So it's a request, right? If you don't mind, please switch on your cameras. Yes. Come back to the subject. If you all have any practical problem with switching your cameras on, that's okay, right? It's not mandatory. So this dating scan, what are the information that you can get? As its name implies, you have to do the dating. So how you do the dating? This is the fetus around this time. There's a head in and there's a tail in. So you have to measure this fetus from top to bottom, the length of the fetus. This is called this length, CRL, crown rump length, CRL. Okay, so when you measure the CRL, if there's a significant difference between the CRL measurement and the mother's according to the dating, you go by the scan date because this is more reliable. To become more reliable, you have to do it between 11 to 14 weeks, remember. If you do it before, 10, 11 weeks, it's not reliable because fetus is too small. If you are doing before, so after 14 weeks, again, that is not reliable. So best time is this. Okay, so I'll show you some pictures. And what else, Darwin? When you do this scan, you can see actually whether this fetus is live or not, whether the heartbeat is there or not. Because sometimes there may be a patient who is coming with a pregnancy and the baby dead. It's a miscarriage. Miscarriage. We will discuss those things later. Okay. So by doing a scan, you can see whether you are dealing with a live fetus or a dead fetus. Miscarriage. Another thing. Dating you can do. You can do the viability of the fetus and some cases that will make. When you do the scan, you can see the number of fetuses. Most of the cases is just one fetus, but some cases there may be 2 fetuses inside, or there may be 3 fetuses inside, triplets, quadruplets, something like that. So currently, you can count the number of fetuses at this time, because the problem is that sometimes if you miss the twin and triplet and quadruple pregnancies during this time, it's very difficult to count the number of fetuses in later scans. Okay, right? So it's very difficult to find out. So this is the best time to see the multiple pregnancies. And in multiple pregnancies, I will discuss these things later. It's a separate topic. It's very important to know. Suppose it's a twin pregnancy, so it's very important to know whether they have 2 separate placentas like this, or else whether they have a single placenta that both fetuses have to share. Okay, so this is called dichorionic, this is called monochorionic. So to detect that, this is one of the very important things in twin pregnancies. Don't worry, new students, don't worry, this will come later in detail. Okay, so to detect this thing, dating scan is the best time to do that. So to detect the chorionicity in twin pregnancies, dating scan is the best time. Because in monochorionics, you will see a T sign, what is called T sign. Whereas in dichorionic, you will see what is called a lambda sign. Lambda means lambda sign. Okay, so T sign and lambda sign. Let me show you some pictures. Right, so this is that picture of CRL, when you get the measurement of CRL, crown is the head and the rump is the back side. Okay, so you measure the direct length of this fetus, CRL. Okay, Darone. So this is the 3D view of fetuses. Now you know 3D scan is also available, so you can have a 3D, a proper picture of your baby. And this is what is I called in twin pregnancies. If you see the picture on your left hand side, Darwani, can you see this? There are two twins on either side, and in between them, the septum in between them is very thick, and on the base it's like very broad base and thick septum to it. Okay, so this is called lambda sign. And we are going to make it, right? Shall we take a deep breath, right? So don't sleep, right? No one can sleep during these 2 hours, okay? I know this is not an ideal time for class, but we don't have any other time, that's why. So this is called the lambda sign. This indicates dichorionic twins, 2 placentas. Whereas if you see the picture on the right hand side, it's a very thin septum. I don't know whether you can appreciate. It's a very thin septum and the base also very narrow base. So this is called T sign. That one called lambda sign, this one called T sign. So please remember, this thing will come later. So T sign indicates monochorionic, lambda sign indicates dichorionic. Okay, so these signs T and lambda also will appear only during the row, only during 11 to 14 weeks time. Okay, Chatushini, right? Only during that time you will get this T sign and lambda sign. Is that clear? So what are the information that you can gain by doing a dating scan, Daro? You can correct the dates. You can see whether the baby's fetus is live or dead, viability. Then you can see the multiple pregnancies. You can see the chorionicity in case of multiple pregnancies. So all these things can be gained by doing a dating scan. The last thing about this dating scan, Daro, when you are doing the dating scan, if you are specialized, you can measure the thickness of the skin pad just behind the neck. That is called nuchal thickness. Nuchal thickness. This thickness behind the neck, skin fold behind the neck. I will show you a picture later. So, if the nuchal thickness is high, that is one of the marker, not 100%. That is one of the marker of Down syndromes. One of the marker of Down syndrome, one of the screening tests for Down syndrome. So that is also can be done between 11 to 14 weeks. Is that clear, Daruni? Right? If I show you a picture, bear with me a few seconds. Yes. So if you see this picture, right, you can see behind the neck, the skin fold, it is very thick here. So this is increased nuchal thickness, indicate or suggestive of arrhythmia. This is Down syndrome. However, Darwani, not confirmatory. This is not a confirmation, just a suggestion of Down syndrome. If the nuchal thickness is high, you can't tell the mother, looks, your baby is Down. No, no way. There's a possibility that the baby can be Down. Can somebody tell me what are the other conditions where you get increased nuchal thickness? This is the skin edema. When the baby is having heart failure, renal failure, Turner syndrome, all these conditions also can increase the nuchal thickness, not only Down syndrome, remember. Okay, not only Down syndrome, right. So we are still in the first trimester and just finished. So what are the things in first trimester that you have to do? So shall we start with the pre-pregnancy time? If you start with the pre-pregnancy care, if the patient is uncomplicated, what are the things that you have to do? Uncomplicated. Just give them folic acid supplements and make sure that they are immune for rubella. Those two things. If they have any medical problems, you have to arrange multidisciplinary care. In addition to folic acid and rubella vaccination. Okay, is that clear? When it comes to pregnancy, Darwani, booking visit, first visit. Booking visit should happen between 11 to 14 weeks. That is the ideal time. Again, you will get the history examination and do investigations. What are the investigations that you have to do? Blood group, full blood count, VDRL, if possible HIV testing, and diabetic screening. Urine full report. Those are the investigations that we do routinely. Then, Darwin, you have to arrange very important a dating scan. Between 11 to 14 weeks is the best time to do the dating scan. You can see the dates, you can correct the dates, and you can see the baby's live or dead. You can see the number of fetuses, you can see the chorion, you can check the nuchal thickness. All these things can be done. And routinely, Darwin, during the first trimester, we are asking the patient to take only folic acid. Okay, so we ask the patient to take only folic acid during the first trimester. Having said that, suppose there is a patient who is 10 weeks pregnant. Okay, 10 weeks pregnant, having COVID pneumonia. Right? Suppose she's first trimester, still in first trimester, having COVID pneumonia. So you guys as students, you all know that during first trimester, you can give only folic acid. So will you treat these patients' pneumonia with other drugs and all, or you will use just folic acid and wait and see till she passed the first trimester? It's not like that, though. If there is no complication, you will give only folic acid. But if there is a requirement, if the mother is at risk of any condition, you have to treat the mother first. Okay, so in that case, you don't consider about the baby, you have to look after the mother first. Okay, because you can't replace a mom, but you can easily replace a wife. If me husband will get a double bonus, he can marry another person, but the poor children at home, you can't replace a mom. So in first trimester, normally we give only folic acid, but Darwani, if there is an indication, you have to treat the patient accordingly. Okay, right. Now come to the second trimester. What are the things that you will do in the second trimester? Now, routinely in Sri Lankan setup, Darwin, in second trimester, you give routinely iron and calcium supplements to the mother. Okay, so as a developing country, it's ever developing. Sri Lanka is ever developing, right? As a developing country, right? Most of the pregnant ladies, they are iron deficient in Sri Lanka. Majority, I mean, major proportion, not the majority, but major proportion of Sri Lankan women, mothers are iron deficient. So there's a recommendation. All pregnant mothers should be given iron supplements. And also the calcium also is one of the things, because the baby is developing, baby needs more calcium. So you have to supplement the calcium also. So after the first trimester, you can start iron and calcium supplements to the mother. Normally, Darwani, you don't give iron and calcium together. Why? Why not iron and calcium together? If you give iron and calcium together, they will bind each other. That will impair the absorption of iron. So, if you are giving iron in the morning, calcium should be given in the evening, or vice versa. But what is the best time to give iron? Is it morning or evening, and why? Does anyone knows? What is the best time to give iron? Why morning? Yes, morning. Very good, very good. Why morning? Yes. If you take iron in the morning, Darwani, with empty stomach, you have more acidity in your GI system, upper GI system, you have more acidity. When you have more acidity, that facilitates iron absorption. Okay, that facilitates iron absorption. So if someone can tolerate, best time to take iron is in the morning and calcium in the evening because of the absorption problem. But if the patient is having severe vomiting and nausea and vomiting in the morning, if he can't tolerate anything, then it's okay to take in the evening iron tablets. Otherwise, best time to take iron tablets is in the morning. Okay, right. So you start iron and calcium supplements. What else when it comes to second trimester? And one of the things I forgot to mention, Daru, first trimester, why we are a bit cautious about first trimester, why we are too careful about first trimester, first 3 months or first 12 weeks, why we are worried? Because that is the time where all the organ development takes place. Your brain development, not completed by 12 weeks, but brain development starts. Brain development, heart, lungs, limbs, kidneys, liver, everything. The development starts during the first trimester. That's why we are not giving any harmful drugs. That's why we are not exposing the mother to radiation, right? So we look after the mother because of that reason. What is the best time or what is the most important time period as far as the organogenesis is concerned? It is whole 12 weeks? No. 3rd to 9 weeks. 3rd to 9 weeks is the most critical time period where your organogenesis takes place. 3rd to 9th week. 3rd to 9th week is the most vulnerable time. Okay, right. That's why even iron and calcium supplements also we are not giving routine in the first trimester because of this organogenesis problem. But on the other hand, if the patient is severely anemic, you can start iron tablets in the first trimester itself. But routinely we don't start. Okay, right. So you start iron and calcium supplements, and what else, Taro? What? So in Srilankan setup, when you come to the second trimester, you have to immunize this mother for tetanus. Tetanus is also one of the diseases that is almost eradicated in Sri Lankan setup. However, still it is prevalent in some. Rarely, you can see 1 or 2 cases, right? This tetanus. So, all pregnant mothers should be given tetanus toxoid, a booster dose. It's not a live attenuated vaccine. It's a toxoid, the part of toxin that you are giving, toxoid, tetanus toxoid. So, after the first trimester, you can give for the first pregnancy. You give 1 dose after 12 weeks. You give 1 dose, and after 4 to 6 weeks, you give the second dose also. So 2 doses will be given during the first pregnancy. Okay, Darwani? Now, she conceived for the first time. So after 12 weeks, you give 1 dose, and after 4 to 6 weeks, you have to give the second dose of tetanus toxoid, 2 doses. Suppose this patient is coming for the second pregnancy, second time she is pregnant. What about tetanus toxoid? So you have to give 1 dose of tetanus toxoid after 12 weeks. You give 1 dose. She is coming for the third time. She is coming for the third time also with the pregnancy. Will you give tetanus toxoid? Yes. You will give another 1 dose. Now, how many doses you have given so far? 2 here, 1, 4 doses you have given. So, patient is going home, coming back with another pregnancy. Lockdown, 4th pregnancy. 4th pregnancy. So, you will give another dose of tetanus toxoid. Another 1 dose. Now, how many doses given, Daru? 5 doses. Husband is a very muscular man, gym, very active person. So patient is coming for the 5th time also with the pregnancy. 5th pregnancy. Will you give program? Sorry, not program. Tetanus toxoid. Sorry, tetanus toxoid again. No. After 5 doses, Daru, no more tetanus toxoid. So you give tetanus toxoid up to the 4th pregnancy. Afterwards, we don't give tetanus toxoid. So first pregnancy 2 doses, following pregnancies 1 dose per pregnancy up to the 4th pregnancy. Okay, so you have to do iron and calcium supplements, and you have to give this tetanus toxoid. Okay, Darwani. Right. Now the first trimester is over. Now patient is in the second trimester. You have done all these things. What is the next landmark? Next important time. Next important time is that for you are to arrange another scan for this lady that is called anomaly scan. Anomaly scan. What was the first scan that we did? It's called the dating scan. It's for the correction of dates mainly. Okay. This is anomaly scan. See the name anomaly. What is anomaly scan then, Daru? To detect major fetal anomalies. Remember, not all fetal anomalies, only major fetal anomalies. So you screen the baby from top to bottom to see whether any major structural abnormalities. Structural abnormalities. Some others will come and ask from your Dr. Baba Sudhindra College. Can you tell those things? You can't tell those things, right? The birthmarks and all those things you can't detect, but major structural things you can detect. Any problem with the skull, any problem with the brain, major things, but you can see the brain, how's the brain? So this looks normal. The inside the brain, the ventricles, then the cleft palate, cleft lip, the maxillary bones, and like that, you can see top to bottom. So what is the best time to do the anomaly scan, Gaurav? Best time to do anomaly scan is between 18 to 22 weeks. Is the best time to do it. So by doing this anomaly scan, Gaurav, you can see, as I mentioned, major abnormalities of the baby. Okay. So you can see the normal, this is what is normal, okay, normal picture, right? So you can see the heart also, 4 chambers, 1, 2 ventricles, 2 atria, and these atria, can you all see here? There's a gap between atrial septum. What is this? Is this a ASD? No. Last week we discussed in our revision, Daro, mixed revisions. What is this? Foramen ovale. This is essential for the fetal life. Foramen ovale. This is not ASD. Okay, this is foramen ovale. So all these things you can see with your anomaly scan. And if you see this picture, Daro, you can see this black color one, all water. Okay, this is water, and this is the brain matter the baby is having. So minimal brain matter, but the brain is filled with water. What is this? Hydrocephalus. Okay, easily you can diagnose these conditions. Right? So, sorry. So likewise, you can see major things. And what is this? Okay, and what is that? I think I haven't mentioned in your handout. You better write it down because these are MCQs. Okay, so I'll explain you all. Let me stop it for the time being. Yes. So most of the anomalies, so major part of the anomalies you can detect with this anomaly scan. So one of the condition is the only this is the baby. Okay, After about after about 7th week, baby is developing fast. Especially the tummy contains the bowel loops, liver, and all these structures, omentum and all these structures developing faster than the rest of the body after 7th week of life. So what happens is this inside environment is not adequate for them to grow. It's not spacious. So what happens is all these bubble loops will be coming out like this. It will be covered and the bubble loops will be coming out. This is called physiological herniation. Physiological herniation. So you will see a physiological herniation, right? That is, these bubble loops and things will be coming out from the wall, right? Around 7th week. And by the time when the baby reaches about 12 weeks, at the end of first trimester, now the abdominal cavity is so spacious, this bowel loop will go back and will seal off the anterior abdominal wall. It will be now like this. Now there is herniation will be auto-corrected. Okay, so this is called physiological herniation. In some cases, Darwani, the baby's bowel loops will be coming out, however, they will not go back inside. They will not go back to the original place by the time of 12 weeks. So then what happens? All the bowel loops will be outside. So all the bowel loops will be outside and it is covered with a thin membrane. Can you see in this picture, Darwin? You can see the bowel loops, you can see the liver. This the brownish color one is the liver. Okay, bowel loops and everything is jutting out and they are covered with the membrane. So on your left hand side, with the scan, you can see these things are coming out. So this is called omphalocele. Omphalocele. So this is kind of a failure of return in physiological herniation. Omphalocele. So the characteristic features are the bowel loops are covered with the membrane. You can see the bowel loops are covered with the membrane. Okay. So Darwani, this is not normally happening. Most of these baby omphalocele, they have other chromosomal abnormalities. So they have other chromosomal abnormalities. So their outcome is poor. Outcome is poor. Similar to that, Darwani, there is another condition. Can you see this one? What is the difference between this one and the previous one? In both conditions, bowel loops are out. But here, in omphalocele, it is covered with the membrane. But here, it is outside. Bowel loops are just came out. They are not covered with the membrane. This is called gastroschisis. 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 The person in front of you will get a nice shower if you say gastroschisis. Okay. So difference between gastroschisis and omphalocele is gastroschisis, there is no membrane covering. Omphalocele is covered with the membrane. Outcome wise, prognosis wise, this has a better prognosis because these babies are otherwise normal. Gastroschisis, babies are otherwise normal. They don't have chromosomal abnormalities. But this condition, omphalocele, babies are having chromosomal abnormalities. Okay, Darone. So just make a notice about that abnormality, because sometimes you can get some MCQs from these two types. There were lots of MCQs from gastroschisis and omphalocele. Okay, so that is one of the abnormality that you can detect with your anomaly scan. Okay, in gastroschisis, actually what happens is this is the baby's tummy. Okay, in gastroschisis, what happens is there is a defect in the anterior abdominal wall. So through this defect, the bowel loops will be jutting out, coming out like that. So after delivery, if you want to close this gap, the baby is otherwise okay. But on omphalocele, they may be having other chromosomal abnormalities, so their outcome is poor. Other abnormalities are like, you can detect future parliamentarians with the anomaly scan. Future parliamentarians, how? People without a brain. So by doing this anomaly scan, you can see, sorry, this picture, right? So you can see this fetus, the skull above the eyeballs is missing. There is no brain. Okay, so this is called anencephaly. Anencephaly. So when you do the scan, you can see these goggle eyes, right? You do the scan, the eyeballs are more prominent. Normally, you won't see this kind of eyeballs in a normal baby. If you see this kind of eyeball, then you know this is an anencephalic baby. This is after the delivery. You can see these babies. No brain. Some of these fetuses, they will die inside, but some of the fetuses can survive up to the delivery. After delivery, they will struggle for a few hours and die. It's so embarrassing to see them struggling after the delivery, especially for the mom. Okay? But these things are happening. This is anencephaly. Remember, anencephaly you can even diagnose at the dating scan. Even at the dating scan, you can see anencephalic babies. When you come to the anomaly scan, definitely you will be able to see these anencephalic babies. Okay, Darwin, right? So you can see these major anomalies with your yes, Charita, little similar to that. I'm not going to tell the name, right? So which is little similar to someone. So so this is called anomaly scan. Okay, Darwani, right? So so far, what are the things we were doing in antenatal care, Darwani? Pre-pregnancy care we have done. First trimester history examination and investigations. Main investigations are full blood count, blood group, blah 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 blah, and a dating scan. Okay, when it comes to the second trimester, you have to put the patient on iron and calcium supplements. And one of the things that you can do in the second trimester, you can do iron and calcium supplements, you can do tetanus toxide, okay? And this is not routinely, but if you are working in a state sector, state means not USA, right? State sector in Sri Lanka, right? So in that kind of an environment, the iron deficiency anemia is so common because of the bookworm infections. Okay, so that kind of a society, you can give them worm treatment also. But it's not a recommendation for all Sri Lankan pregnant mothers. So those who are having high risk, you can give worm treatment as well. Something like mebendazole. If you see the BMF, these are contraindicated during pregnancy, but actually speaking, these things can be given during pregnancy, if necessary, after the first trimester. Okay, so in the second trimester, what are the things that you can do, Darwani? Iron and calcium supplements, tetanus toxoid, worm treatment plus or minus, right? And one of the major things is anomaly scan. Okay, anomaly scan. Now, still we are in the second trimester. Okay, right. Then, now, after this anomaly scan, next important thing is between 24 to 28 weeks. Next important thing is between 24 to 28 weeks. You have to re-screen all pregnant ladies for diabetes again. You have to screen them again for diabetes between 24 to 28 weeks. Okay? How will you re-screen? Normally we do OGTT, oral glucose tolerance test. Oral glucose tolerance test. Okay, Darwani, right? Why you are re-screening them? Please remember, right? Now, I told you, when it comes to the dating scandal, the booking visit also you do OGTT. At booking visit, if OGTT is positive or high, what is your impression about the patient? So new students, don't worry, Daru. There are two types of diabetes in pregnancy we discussed. There is chronic diabetes, chronic long-standing diabetes, like diabetes that you all know. Other thing is called gestational diabetes. What is gestational diabetes? Pregnancy. Pregnancy-specific diabetes. Boys, you will never get gestational diabetes, provided you are a boy. I'm sure. Right? So, there are two types of diabetes. There is chronic diabetes and gestational diabetes. Now, why we are doing this OGTT test at booking visit is to detect any hidden chronic diabetic patients. Because I may be a diabetic patient, but I'm not showing clinical features. That is called subclinical diabetes. If I take the students in this class, say how many students here? Yeah, there are 66 students, right? At least 2 or 3 of you guys may be having diabetes, but never detected. Okay, so when you become pregnant, it's very important for you all to detect diabetes. That's why, Darwani, we are doing this OGTT test at booking visit itself. Okay, suppose at booking visit, if OGTT was normal, what is your impression about the patient? OGTT was normal at booking visit. You are not a chronic diabetic patient. You are not a diabetic patient. Okay, if that was negative at booking visit. However, Darwani, even the OGTT was negative at booking visit. There is a condition called gestational diabetes. This is usually occurring or appearing after 20 weeks. So you re-screen them around 24 to 28 weeks. Main purpose is to detect this gestational diabetes, GDM, gestational diabetes. Okay, so remember. At booking visit, if the OGTT was high, then afterward you manage the patient as diabetes in pregnancy. You never repeat this OGTT test again for those who had positive test at booking visit. At booking visit, if OGTT was positive, then you can say for sure you are a diabetic patient. So don't do this OGTT test again at 24 to 28 weeks. What will happen? Suppose if I'm a diabetic patient, if you give 75 grams of glucose, what will happen to my diabetes status? It will be sky high. Okay, it's confined here. You can't do OGTT again. Okay, this is for home. At booking visit, no diabetes. Now, however, you may be having what is called gestational. For those who had negative test at booking visit only, you redo it at 24 to 28 weeks. Is that clear? So don't offer OGTT again for all pregnant mothers. This is for the people who had a negative test at booking visit. Only you do OGTT. Okay, right? Good. Then, when you do the OGTT at around this time, if the booking visit was negative, now it is high OGTT values. What is your impression? What is the impression about the patient? Most likely, she is a gestational diabetic patient. She has developed gestational diabetes mellitus. New students, don't worry about this gestational diabetes, chronic diabetes, and all, how to manage and all. Those are separate topics that we need to discuss in detail later. Okay, right? Right. In addition to this, in addition to this glucose screening, you have to do another full blood count, and this time a full blood count to check again whether the patient having anemia or not. So around 24 to 28 weeks, you have to do two tests. One is OGTT, one is full blood count. Full blood count and OGTT. Is that clear? Right? So booking visit, history examination, and full blood count, blood grouping, VDRL, OGTT, if facilities available, HIV, and UFR. Then after the first trimester is over, you have to put them on iron and calcium supplements, tetanus toxoid, and those who are having high risk, worm treatment. Around 18 to 22 weeks, you have to arrange a proper anomaly scan. Okay, Darwani? And around 24 to 28 weeks, you have to rescreen them for diabetes. And also, you have to recheck their hemoglobin level also here. Then afterwards, there is no specific antenatal care. Now, so far we have done two scans. What are those two scans? Dating scan and anomaly scan. Those are two mandatory scans for pregnancy. Dating scan and anomaly scan. Afterwards, you don't have to do any routine scans. However, if you detect any problem afterwards, you can do a growth scan. What is called a growth scan. So in the third trimester, you are doing growth scans if necessary. Not routinely, but if necessary, you can do growth scans to see the baby's growth. It's not for the correction of dates, it's not to detect anomalies, but to confirm or to reassess the patient's baby's growth. You can do growth scans. Okay. So after 28 weeks, there is no specialized antenatal care. Like that you have to do this thing at this time, this thing at that time, not like that. So by the time when the patient reaches 28 weeks, most of the problems you have identified. If there is no problem, you manage as low risk. If there's a problem, you have to manage accordingly. Say, for example, if you have found that the patient is diabetic, you have to have a specialized diabetes management. If you have detected that the patient is in high blood pressure, You have to manage accordingly, something like that. Routinely, there is no routine care as such. However, Darwin, okay, when a patient, so this is basically the routine and natal care. Whenever a patient come to the clinic, what are the routine things that you have to do? What are the routine things that you have to do? Okay, booking visit. These are the routine things. Booking visit. What are the routine things that are you have to take history, examination, and investigation. You all know what are the investigations that you have to do. With regard to the examination, one of the things is BMI. You have to measure body mass index. BMI. You know BMI? Yes. Right? So if the BMI is low or if the BMI is high, both are risky conditions. BMI should be normal, the normal limits. Okay. So that is in the booking visit, history, examination, investigation, and all these things. Then after each clinic visit, what are the things that you have to do? You have to get a quick history like, how are you? Is your baby moving? Are you feeling okay? Like that, you just have a talk with the patient. The examination wise, what are the things that you have to do? Not in the booking visit, but afterwards. Now, booking visit also you have to do these things, but afterward each clinic visit, what are the routine things that you have to do? Examination wise. Examination wise, you have to measure the weight. Initially, you have done the BMI. Afterwards, you don't measure the BMI. It's no point. On the booking BMI, then each clinic visit, you have to measure the patient's weight. And also, you have to measure the blood pressure, very important. Okay. Weight, especially the blood pressure, is extremely important. Investigations, what are the routine investigations that you will do? You do what is called two-word test. Urine word test. For what? You do urine word test for reducing substances. What is the test that you will do for reducing substances like glucose? What is the test? Benedict's test for reducing substances. And you have to check urine for protein. With heat test, you heat the urine and do this test. Heat test. So each clinic visit, you have to measure the patient's weight, patient's blood pressure, and urine water. These are all MCQs, urine water tests. I haven't included those things in your handout purposefully because you all need to write down something. Okay. So urine water test basically for two things: for reducing substances like sugar, that is the Benedict test, and for the protein, you have to do the heat test. Guys, can you all remember in your biochemical era how to do this heat test for protein? So I just tell you all how to do that because these things are important, especially when it comes to vivas. So the most difficult thing is to find the urine sample, two sample. Okay, so take about half of this is a test tube, half of urine. Okay, then you take a burner, Bunsen burner or something, and you boil this urine. When you boil urine, if there is protein, it will make a precipitate. It will make a precipitate. Okay, right? So what else can cause this precipitate? One is protein. What else can cause this precipitate? What else can cause this precipitate? Phosphate. Phosphate also can cause the same precipitate. So how will you differentiate whether this is protein or whether this is phosphate? You add few drops of vinegar or acetic acid. Acetic acid, few drops. Something like that. Okay, few drops. If this is phosphate, they will dissolve this precipitate. If it is protein, that will be persisting. That is called urine wart test for protein. You take a sample of urine, boil it, and let it cool. If there is a precipitate, there are two possibilities there. One is it may be protein, one is it may be phosphate. Okay, right? Maybe urine, maybe phosphate. So to differentiate them, you have to add few drops of acetic acid. When you add acetic acid, if this is phosphate, that they will dissolve the precipitate. If this is protein, the precipitate will be persisting. Then you know whether the patient is leaking protein or not. So, routinely for each and every clinic visit, you have to measure the patient's weight, blood pressure, measures weight, measures blood pressure, and do investigations like urine wart test. This is for each and every patient, for their each and every clinic visit. You have to check their the sugar, that is reducing substances, actually reducing substances with Benedict's and protein with heat test. Is that clear, Darwane? Okay, any problems so far? Right. So basically, this is antenatal care. So please remember, antenatal care usually start with the pre-pregnancy time, pre-pregnancy counseling. Okay, so pre-pregnancy counseling, what are the things that you have to do? First trimester, what are the things that you have to do? Second trimester, what are the things that you have to do? And the third trimester, what are the things that you need to do? Okay, right. And in this antenatal care, I have included this Down syndrome screening as well. Okay, Daru. So, who are the people who are having high risk of Down syndromic babies? Elderly mothers. He is okay for a father, but the mother's age, when the mother is getting old and old, there's a chance, higher and higher chance of Down syndrome. Right? So, especially if the mother's age going above 35. My God, 10 years. Right? If your age is going over 35, the chance of Down syndrome is significantly rising. So, girls, what is the take-home message today after this free class? Try to become pregnant before 35. Okay. You may be touching 35 now. So, whatever it is, right? So, elderly mothers are having high risk of Downs. Who else? Mothers who had Down syndromic babies in her previous pregnancies. There's a chance. For those, Darone, what are the things that you can do? How you can screen them for a Down syndromic baby? Down syndromic baby. So first thing is, as a screening test, we can offer what is called nuchal thickness measurement. Nuchal thickness. Can you remember NT nuchal thickness? Yes. This is behind the neck. You measure this skin fold. If the nuchal thickness is high, the chance of Down syndrome is high. Not 100%, Darwin, chance is high. If the nuclear thickness is less or small, then the chance of Down syndrome is less. Is that clear? Right? So there is one of the non-invasive tests that you can do to detect Down syndrome. Suppose if the NT, nuclear thickness, is high, then you know there is a possibility of Down syndrome. How you can confirm it? You can gain further the assessment by doing various blood tests in the mother. Okay? So you can do several blood tests in the mother and you can tell, okay, look, these tests are also positive, so your chance of Down syndrome is high and high. But you can't say for 100%. What are these tests, Darwin? There are various tests. One is called the combined test. Combined means that you combine nuclear thickness plus some other blood investigations like beta HCG and pregnancy associated plasma protein A, PEPA. And likewise, you have triple test. You have combined test, you have double test, you have triple test, you have quadruple test. So I have given you in your handout, right? What are the components of this test, right? So just go through them, and you have to by heart those things. It's not easy to remember those things, but you need to by heart those things. Those are MCQs. Say, for example, you may get an MCQ asking, what are the components of a triple test? What are the components of a double test? Or what are the components of a combined test? Something like that. So they will predict Down syndrome to some extent, maybe 80%, maybe 85%, but they can't say for sure whether this baby is having Down syndrome or not. Those are all considered to be non-invasive tests because you are not going to damage or prick the baby. So those are considered to be non-invasive tests. Okay. So if you want to confirm whether this baby is having Down syndrome or not, you have to go for what are called invasive tests. There are various invasive tests available, Darwani. There are various invasive. This is the nuclear thickness. Okay. Now this is one of the tests. This is called amniocentesis. Not amniocentesis, it's amniocentesis. Amniocentesis means that under ultrasound guidance, you insert a syringe into the amniotic cavity and withdraw a sample of amniotic fluid. This amniotic fluid contains cells which feed off from the baby's skin. Okay, so those cells contains, those cells, they contains DNA within the cell. So you can take the DNA out and you can see whether the baby is having trisomy or not. Trisomy 21 or not. So this is one of the best tests that you can do to assess, to confirm. This is a confirmatory test to assess whether the baby is Down syndrome or not. To do this amniocentesis, baby should be at least 15 weeks or more. 15 weeks or more. That means in the first trimester, you can't do this test. 15 weeks or more. Okay. Other thing is, Darwani, same way, rather taking the amniotic fluid, you can take few cells or a biopsy from the placenta. This is called chorionic villus sampling. So you do the scan under direct vision, you can insert a needle and aspirate few placental cells. This is called chorionic villus sampling. Okay, right? So if you do this test, then you can analyze the chromosomes and see whether the baby is trisomy or not. One of the advantage of this test is that this can be done after 10th week. So if you're going for amnio, you have to wait till 15 weeks. But this test can be done after 10th week. That means 11 weeks onwards, you can do this test. So if you want an early diagnosis, what is better? Choreo is better because you don't have to wait till 15 weeks. You can do it after 10th week. But the sensitivity wise, amnio is better than choreo. Okay, because the problem with these placental cells is some of the placental cells may be normal, some of the placental cells might show trisomy 21. So there's a chance that you may miss the real fetus with the Down syndrome, even with this choreo. Not a greater proportion, but there's a slight small chance. So in that case, amnio would be the best option to confirm whether the baby is Downs or not. Okay, Darwani. So amnio is going to be done after 15 weeks. Choreo is going to be done after 10th week. Both of those tests are considered to be confirmatory tests for Down syndrome. There is another test that you can do, Darwani, that is called cell-free DNA technique. Cell-free DNA technique. Where what you do is rather pricking the baby. Now in this amniocentesis and chorionic villus sampling, you are directly putting a needle into the amniotic cavity. So there is a possibility of a miscarriage by doing this procedure. Chance is about 1%. There is about 1% chance of a miscarriage because of the procedure itself. Okay, procedure itself can cause some miscarriages. Okay, so it's a risky procedure. Okay, so that is why people are a bit worried about. There's another test that you can do, that is you take a sample of blood from the mother. In the maternal blood, there are some fetal DNA in the maternal blood when she is pregnant. Fetal DNA in maternal blood. So you can purify those DNA and you can analyze the chromosomes. That is called, Darwani, cell-free DNA technique. Cell-free DNA technique. That can be done after 7th week. So if you want an early diagnosis, that is one of the better option. Okay, that is called cell-free DNA technique. Can be done after 7th week. The problem is in Sri Lanka, it's very costly. About a few years ago, it was about 70,000 rupees. By now, it may be definitely near 1,000. I mean, it's almost like doubled. Okay. Double, yes. I know that, but it's double. So it's better to have a Down syndromic baby rather than spending that much of money on this test. Okay. Okay, cell-free DNA technique. So what are the confirmatory tests for Down syndrome, Daru? Best thing is still amnio. You can do the choreo and you can do the cell-free DNA technique. Remember, amnio and choreo, they have a risk of causing miscarriages, whereas cell-free DNA is quite safe to the mother. Sensitivity, of course, if you compare with the amnio, sensitivity is little, not too much, it's little less. So the best thing still would be amnio. Okay, right. Is that clear? Is that clear, Darwani? So today I have discussed the antenatal care in Sri Lanka. Okay. So what if I sum up everything, Daru? I start with the pre-pregnancy care. Before pregnancy, what are the things that you have to do? Then I discuss In the first trimester, what are the things that you need to do? When it comes to the second trimester, what are the things that you need to do? And in the first trimester, what are the things that you have to do? And I told you all, in each and every clinic visit, what are the routine examination things? What are the routine investigations, that is as urine? What are the things that you have to do? Then I discuss in little detail regarding this Down syndromic screening. Okay, what is nuchal thickness? What is the best time to do nuchal thickness? Say, for example, Darwani, in the exam, you may get a patient who is coming at, say, 17 weeks. Okay, 17 weeks, worried about a baby because of a possibility of Down syndrome. What are the tests that you can do? In that case, definitely nuchal thickness you can't do, because nuchal thickness is up to 14 weeks. So if you detect nuchal thickness as the first line investigation, your answer is wrong. So you have to read carefully. Okay, so you can do the nuchal thickness, you can do the combined test, double test, triple test, and quadruple test. Okay, and if you want 100% confirmation, amnio would be the best option. But it's late, it's after 15 weeks. So if you're going for a termination afterwards, that's going to be a little bit difficult with amnio, because 15 weeks means a big fetus. If you want the earliest confirmation, that is cell-free DNA would be the best option after 7th week. Choreo after 10th week. Okay, Darwani, right? So we have one patient we need to discuss. So before I finish off, right? So I'm going to start the theory session soon. Okay, so I'm going to do depending on the number of students, but definitely I will do some live classes like this way, live important things, live classes, as well as some restreaming. But if there are students, adequate students, then we'll be able to consider doing all live classes. Okay, so if you think that if my teaching pattern is good, or if you think that this guy can do something, please enroll with these theory sessions, and I will make sure that I will do all theory parts in adequate amounts. Okay, so I will make sure that I will cover your syllabus A to Z, everything, including everything. Okay, so that doesn't mean that I will not train you all to become a registrar or a consultant. Your target is to pass the ERPM exam. So I will do all necessary things related to your ERPM exam. Please keep the trust on me, because I have been in this field except last year for years and years. So I know the syllabus. I have done, you can ask from the previous students that who came to my classes before. So I will do all the necessary things in adequate amount, and I will cover the revision as well. So I'm going to start my theory sessions from 7th August, that is the Saturday onwards. And I will keep you all updated through my WhatsApp groups and other groups. So registration is already open. So those who wants to join, you can join with the classes, right? 7th August onwards, we'll be doing all the details. I will send through these groups. Okay, shall we discuss that question, Darwani? So to take your time. Yes, I think one is missing here. Sorry about that. 42 years old, mother of one child, came for a booking visit at 11 weeks. So she's an elderly mother, 42 years, isn't it? She is worried about this pregnancy because her first baby was having Down syndrome. Obviously, because of the first baby was Down syndrome, she has a risk. Because of the age also, she is having a very high risk of Down syndrome. Which are the following tests that you will offer her as the first line investigation? Sorry, only 4 options are given. There should be 5th option, that is NT, nuchal thickness. So this patient is having a nuchal thickness. The 5th or the E, response E would be nuchal thickness. So out of those 5 options, what is the best option for this patient? So scenario is clinically, she is having high risk of Down syndromic baby. She is now coming at 11 weeks. As a doctor, what is the first line investigation you will offer to this patient to exclude or to include Down syndrome? Normally, Darwane, we don't offer these invasive tests as the first line investigation. So see the answers. Karyotyping. Yes, you can do the karyotyping, but do the karyotyping, you have to do either amnio or choreo or more expensive cell-free DNA technique. Okay, we will see. Amniocentesis. I would say amnio is not the answer for this patient because of two reasons. What are the two reasons? Amnio is false. Charita, what are the two reasons why amnio is not correct for this patient? As an answer.
Gestational age, week.
Other gestational age, very good. She's still 11 weeks. So it's contraindicated to do amnio at this time. You have to wait at least 4 more weeks to do, at least 1 month to do the amnio. Yes, what is the other reason, Daru?
Amnio is invasive.
Yes, exactly. Amnio is an invasive test. It itself can cause miscarriages. So because of that, we don't do amnio as the first line investigation. That is false. CVS, chorionic villus sampling. Can you all do at this time 11 weeks? Yes, you can do. But the problem is it's also an invasive test. So we don't do invasive test as first line. Double test. Double test is kind of a blood test. Other thing is nuchal thickness. We'll come to the last one first. Nuchal thickness. Can you all do nuchal thickness at 11 weeks? Yes, that is the best time. 11 to 14 weeks is the best time. So that is one of the good things. Time period is okay. 10. What is the other thing? Other thing is
specific. It's not specific for Down syndrome.
That's true. None of the tests are specific other than amnio, choreo. The other problem is nuchal thickness is just non-invasive test. It doesn't hurt the baby, it doesn't hurt the mother. Whereas double test or triple test or quadruple test, you have to prick the mother and take blood. But this one, nuchal thickness, just a scan find. It's non-invasive, so it doesn't disturb the baby or the mom. So as a screening test, we usually first line is nuchal thickness. Then afterwards, you can do the combined test or triple test or quadruple test, whatever it is. Then if they are also suggestive, then you have to consider amnio, choreo, or cell-free DNA. Is that clear, Daruna? So answer would be nuchal thickness. However, remember in the exam, the same question, there's a possibility that patient is coming after 14 weeks. In that case, nuchal thickness is out. Okay, clear? So think carefully and read carefully the whole question. Then, one of the other thing I want to tell you all, I forgot it actually. Yes, sorry, one more thing. Have you all heard of Naegele's rule? What is that, Darune? Now, just I won't take much time from you all, Darune. Now, how can you calculate the number of weeks or the expected day of delivery of a patient, of a pregnant patient? How will you calculate it? Now, you can calculate the expected day of delivery, EDD, by 2 weeks. Two methods. One is clinically, other one is ultrasonically. Okay? So clinically, you can calculate the expected day of delivery. How? If you know the first day of last menstrual period, this is called LMP. First day of last menstrual period, you can calculate the expected day of delivery. How? By adding 9 months plus 7 days. I have 5 more minutes to go. Okay, I will finish it before that. Huh? So stay with me, Darone. So you can calculate the expected day of delivery if you know the last menstrual period by adding 9 months plus 7 days. For example, suppose I am now pregnant with a large tummy, right? So my last period was, say, January 1st, 2021. 1st January 2021. When is my expected day of delivery? You add 9 months plus 7 days. So 9 months when you add here, it will be October. 7 days, it will be 8, 2021. So my expected day would be 8 October 2021. How did I calculate that one? If you know the last menstrual period, you can calculate the expected day of delivery by adding 9 months and 7 days. To do this, though, there is a limitation. There is a condition. Okay, so you can't calculate in this way for each and every patient. If you listen, everyone, stop everything, don't think about anything else, just think about this thing. Leave your boyfriends and the girlfriend for a time being, just for 2 minutes. Right? So concentrate on expected day of delivery. So I told you that if you know the last menstrual, first day of last menstrual period, then you can calculate the expected day of delivery by adding 9 months and 7 days. To do this, patient must have, prior to pregnancy, regular cycles. The menstrual cycles must be regular prior to conception. That means if the woman had irregular cycles, irregular periods before the conception, then you can't calculate the EDD by this method. That is one condition. What is the other condition? Prior to conception, she should have not been on any hormonal contraceptives. No hormonal contraceptives prior to conception. If those 2 criteria are fulfilled only, then you can calculate the expected day of delivery by adding 9 months plus 7 days. What are the 2 criteria need to be fulfilled, Darwani? What are the 2 criteria? No contraceptions prior to conception, and the cycles would have been regular prior to conception. What do you mean by regular cycles? This is a question, complete question. That's why I'm telling you. What do you mean by regular cycles? What should be the duration of a cycle to become regular? 28 days? Do you think 28 days? If I ask personally from the girls here, none of the girls may be having 28 days menstrual cycles. It's varied, right? So what is the normal duration of menstrual cycle? It is 28 plus or minus 7. Right? 28 minus 7 means 21 to 35. So prior to conception, though, this patient's cycle duration should be between 21 to 35 days. Say, for example, if the patient says that, doctor, before I got pregnant, doctor, my cycles were very irregular. I got once in 40 days, 45 days, once in 2 months time, something like that. Then can you calculate the EDD by adding 9 months and 7 days? No. Or as if the patient says, doctor, almost every day I am having bleeding, I had bleeding, and after 15 days, 16 days, I am having something like that, less than 21. Then can you calculate EDD? No. So cycle should be between 21 to 35 days. No contraception. Then you can calculate the expected date of delivery by adding 9 months and 7 days. Okay, Daruni. So in the exam, if they have given a last menstrual period and asked you to calculate the expected day of delivery, please make sure that patient had regular cycles before and no contraceptions. Then only you can calculate EDD. If not, how can you calculate EDD? By doing a dating scan, 11 to 14 weeks. Dating scan is the next option. Is that clear, Darwin? So today, we have discussed, now the time is up, we have discussed an important basic topic in obs and gynae, okay, that is antenatal care. I hope you all had an idea about antenatal care, okay. So there are new students here, don't worry, if you join with the theory courses, I will explain you all about all these gestation diabetes and all the other theory parts in detail later. So keep trust on me, right? I will make sure that I will make you all a confident person when it comes to the exam, to face any of the exams. Thank you very much for joining today. And I'm sorry I took 1 minute more. And have a good sleep and get ready for tomorrow. Okay. Thank you very much for coming and joining today. Thank you.